Tá bem.
So I just tried my slide, so I think it worked. So it should not be any glitch. Hi, Cecilia. Good to see you. Hi, Jose. Yeah.
Hi, Peng. How are you doing?
Yeah. So you have your wine so for toasting.
Yes. No, I have my wine here, and I wait your wine, my friend.
Oh yeah, I have everything there. I have everything there.
Okay.
Oh, this is Andre Mazzano. You look so serious. What's wrong? Okay.
Now, moment. Yeah.
Cecilia, is it your daughter? Oh yeah, you're mute. You're mute.
Hi, now I can talk. Hi, Philip. I'm sick, Philip. I'm in bed.
Oh, wow.
No
my-
wine today.
No wine today. Okay, so we need to look after ourselves. Yeah, just sorry to hear that. Yeah. Okay, I'm going to mute myself. Stop the video until Jose is ready. I'm going to have a sip of wine. It make my talk feel better. I need a little bit wine. Yeah.
Yeah, good thing, my friend. Thank you. Deixa eu abrir aqui para a mesa. O...
Olha o mil.
Oi, pessoal. Chegou cedo, hein, Mil?
Cedo, sem roupa do centro cirúrgico. Coisa linda, hein?
Ele sempre está dentro do táxi, no avião. Não é
Sim,
possível.
não tá no avião, não tá no trem.
É.
Isso. Saudade de você, Cícero. Você é a única que não me mata aqui. Eu estou aqui tentando. Eu tô literal. Deixa eu acender essa luz aqui, não está escuro, né? Tô literalmente tentando.
Será que ele está com muita diferença lá de horário, André? Sabe, Toronto, como é que está lá?
Eu acho que são 2 horas menos, né?
É 1 hora.
1 hora.
1 hora. Hoje ele vai bater o recorde do Godoy da última vez lá.
Tomara. Ele vai curtir.
Vai.
Se não bater, você fala que bateu.
Sim.
Não tá, não. Quer dar minha lugar? Então eu vou pegar esse colchãozinho para outro lugar. Fala. Aqui. Só que no outro sítio também.
Eu acho que eu já vou fazer uns anúncios aqui antes dele
Boa.
startar. Eu escrevi para ele aqui, não sei se ele está só à distância. Bem, vou começar aqui os anúncios, então. Hoje é um dia especial para nós, né? Nós temos aqui um convidado muito especial, o Dr. Peng, é uma sumidade internacional, todo mundo conhece, é extremamente conhecido. E eu vou até citar um currículo, um mini currículo dele, mas ele é professor do Departamento de Anestesiologia da Universidade de Toronto, no Canadá. É um líder, pesquisador, educador, pioneiro na aplicação de ultrassom e outras técnicas aí na medicina da dor. É divulgador das técnicas, e muitas delas ele pesquisa a fundo, ajuda no desenvolvimento delas. Publicou aí mais de 200 artigos, foi editor de 8 livros, tem mais de 350 palestras e workshops internacionais e nacionais. Então, é extremamente conhecido. Então, para nós é um grande prazer. E eu gostaria também de colocar aqui que, aproveitando esse momento especial do convidado, nós vamos fazer alguns sorteios bastante importantes aqui para nós do mundo da dor, com o apoio da Sobramid, que é sempre que é a mantenedora dessa plataforma nossa aqui. Nós teremos um sorteio de 3 inscrições do Simpósio de Dor e Acupuntura e Tratamento Multimodal na PM de Santos, uma inscrição do Cabidor da SBOT, do Comitê de Dor da SBOT, que será em São Paulo também, uma inscrição da Sobrice, que é a Sociedade Brasileira de Radiointervenção, e, e também uma inscrição para o Congresso Brasileiro, e uma outra do Lagos Dor, que esse ano é o único evento nosso aqui da Sobramídia Oficial, que também tem um simpósio de dor oncológica. Então, nós vamos ter aí vários sorteios. As aulas todas do Peng são gravadas. Nós sempre pedimos aí que vocês sejam sócios da Sobramid, a única sociedade brasileira de dor, realmente médica de dor. Nós temos aí o intuito de crescimento, estamos aí já com uma filial aberta, que foi a de Goiás, a de Goiânia, né? E estamos aí abrindo aí outras filiais. Temos os patrocinadores também a agradecer bastante, que sempre nos apoiam, que é a UOMED e a Genesmed. E coloco aí que todas as aulas estão sempre gravadas no YouTube, são aulas gratuitas. Então, é sempre aí importante que vocês tenham acesso às aulas, fiquem lá, façam inscrição no canal do YouTube, tem também o link no Instagram, que é o Peng Oficial, e acredito que seja isso. Não sei se vocês aí da mesa querem falar alguma outra, algum agradecimento antes da abertura aí. Muito bom.
Então, agradecer a todos pela presença já, né?
Ah, com
E
certeza.
torcendo já para começar a aula. Está todo mundo
Exato.
querendo assistir.
Vou tentar chamar aqui. Vamos ver como é que está nosso amigo. Também agradecer os convidados aqui, pessoal, internacionais. Aí nós temos convidados do mundo inteiro participando, assistindo essa aula, e como, por exemplo, México, Chile, Argentina. E eu queria agradecer a todos presentes aí.
Okay, good.
Ok.
Good. Sorry, I don't understand what you just talked. Let me know.
I know. Good evening,
My
Dr.
Portuguese is
Peng.
so poor.
Okay. Good evening, Dr. Peng. Good evening, everyone. I'd like to thank you, Dr. Peng, for speaking tonight. It's an honor to have you with us. It means a lot. You're ready to start.
Okay, great. Well, let me just make sure my screen is okay. And then I share the screen. I think, great. So Jose or CC, if you cannot see the screen, let me know. But I think I'm
Yes.
okay.
It's okay.
So Jose, thank you very much for the invitation. Always love to be connected to Brazil. I can't wait. And as a matter of fact, in another 5 weeks, I will be in São Paulo again. And so looking forward to connect with all my friends This format a little bit different from what I usually do. Usually I just go down to business and say I give my talk. Jose asked me to talk about my wine, and for those who know me, I'm a Chinese, but my liver is made in somewhere else. So I love wine. I just love wine. So one of my passion is I love the red wine. I love all type of alcohol, but the red wine is my favorite. So today, the wine that I'm going to choose is, I'm not too sure you heard about this, is called Amalone. Amalone is a wine especially from Italy. Is a very special wine, and I do know in Latin America you have tried this, but I'm going to give you a little bit of a introduction. So it is Amalone. The name means is a little bit dry and bitter. So, but even though it's dry and bitter, there is a certain sugar level that actually make it bittersweet. It's coming from a very special region. So in Italy, the northern part is called Veneto, is very famous. But within the Veneto, the area is called the Valpolicella. So that's why it's called Amalone della Valpolicella. And for those who love wine, you know that sometimes the wine manufacturers, the organization, they give a little bit of a kind of a categorization. And so for those wines, say in Canada, when you have a label called VQA, is actually reach a certain standard, or in French, the appellation de contrôle, or in Italy, is a DOCG. So you can see actually is a kind of wine which has a certain standard. I just need to disclosure, I'm not a wine expert, I just love wine. And I have no conflict of interest with the Amalone wine or the producer. So when you try wine that say Cabernet Sauvignon, you know the grape, you like Sauvignon Blanc, Merlot, Malbec, you know the grape right away. So Amalone is very common in a lot of Italian wine or French or Italian wine. Basically, it's a mixture of different grapes. The main grapes is a Corvina, or sometimes actually they substitute with a Cabernet. So they are the main ingredient, more than actually around 50% or more. They mix with Rhodinella and Monanella. So, but the common Comana is one of the most important ingredient. As I say, that the Veneto is a famous winery region, and the red area is Montepulciano. So this is actually the area that produce with the climate, with the soil, it's just perfect for this type of the different grapes that you haven't heard about usually. What's so special about this wine? So most of the time, the worker, they harvest the grapes, they actually put it, crush it, and ferment this. So this is the usual process, but they don't. So for this wine, they put it in a certain basket like on here, and they let it dry, and just let the air dry. And so the process sometimes the special name called appassimento, it can be up to 4 months, 120 days. So it just make a lot of labor intensiveness for this type of wine. But because of this, it lost 30 to 40% of the water content. Now, what's so important about this? First of all, the alcohol is a little bit more because it ferments high content sugar. So a typical Amalone wine is 15% or more. Can be 15, 16, or even 17. So most of the time is around 15 to 16%. As I say, Amalone is it literally means dry bitter, but actually because of the dryness, it actually have a little bit more sugar. So it's kind of bittersweet. So it's actually kind of very interesting sweet taste. And also with the dryness, it increases the contact between the skin and the grape. It polymerize the tannin. So it actually have a lot of interaction with tannin. For those who like red wine, they love the taste of tannin. That actually is a good thing because you have a more process to process the tannin. Well, think about this, all this labor-intensive work with more grapes to produce the same volume of wine because it lost the water content. It means it's a bit more expensive. So in general, a reasonable wine in Canada, we are not talking about, I'm just a humble doctor. So a good wine probably usually just a very reasonable wine is around $20, but the entry price for the Amalone usually is $50 or more. So that's make it a little bit more expensive. How does it taste? Is a full body because of the high alcohol content, lower acidity, and a little bit more glycine inside. For me, I would say I would describe more like a currant, dark currant, dark red berries. Sometimes people say it's berry jams and prune, but it's very rich in texture and very smooth. We say when you taste it, if you don't know what's the meaning of smooth, when you taste it, just smell and taste it. The first sip, you know what is the meaning of smooth. Why I like this? Well, I love red wine, and so this is the perfect for me. Is a dry bitter, a little sweet, dry bitter sweet. So it's a dry bitter, a lot of tannin product, and it's full body, low acidity. When you read the literature, they always say it's a rich wine, so that it's supposed to pair with a rich food, especially those are slow cooked hearty stew. You don't want to spoil the food because of low acidity. You don't want to put a lot of spicy food there. But in my just a bit humble opinion, there's a few things. I find this wine is quite good. You just open the bottle. You don't need much aeration. You can just drink, but just swirl slowly and just let it aerate a little bit while you're drinking. That is enough. You don't need to just have a little bit aeration. So just drink right away from the bottle. Just drink slowly. You can get all the aroma from this. The other thing is that better to drink. I would say most of the time you drink wine with the food. I would say actually so when I drink this, just before the food, I drink it. It's good. And when I eat something, it just changed my taste a little bit. So it turned out that a lot of wine experts, they also say the same thing. Much better drink as we call it wine of meditation. So you can just drink without any food. Just open the bottle with your friends, with a fireplace beside you, or have a nice wilderness and with your friends and chit chat a little bit. Just drink, and then without maybe a little bit of crackers, but just you don't need to go for the dinner to drink it. And it's rich and smooth, and it's a very powerful feeling when you first drink. And I would say I introduced this wine to a lot of friends when they come to Canada, and I just say, order this Amalone. Everyone just love at the first sip, So this is Amalone della Valpolicella. So I think this actually is just a little bit of a sharing with you about the wine that I love. I love basically every single wine, just whenever it's good wine, I won't resist. But this is the one that I would say this is one of my favorite.
Okay. Good choice, my friend.
Yeah.
Very good choice.
Yes. For those who have a wine glass, actually, it's just yeah. Wow, just feeling the aroma is good. Now I drink 2 glasses already, so don't want to drink too much because I can't. If I talk a little bit incoherent, then you will know. Okay. Any questions? Any literature review you want me to do?
No.
Okay.
Thank you.
So I go ahead to my main topic. Let me see. Actually, here you go. Okay, I hope you also see this is a topic that I have a lot of interest about this for the last many years. I not just I have a lot of interest, I have a lot of technical experience and also a lot of thinking behind this. I feel that actually a lot of time people, it's like a blind leading to the blind, follow the trend. For those who know me, like Andre, as you see, I love to argue. I always love to look at actually, is it really that the case? Try to actually understand a little bit. So I would like to share with you some of the things I know about the need denervation. as a matter of fact, we are going to write a review article. It's about the lessons we learned in the last 12 years. But I'm going to just give you a few of those points. I'm not going to give you all the points because I want to keep it 30 minutes. My disclosure slides, a lot of those information is coming, and especially pictures coming from these few books. When we talk about denervation, we always talk about in the past for Peng specialists, the denervation in the spine, especially lumbar facet, cervical facet, or recently SI joint. But hip and knee and shoulder is getting more and more popular among Peng physicians. I see the new trainee, they also start to have a lot of interest. They are doing this now. But focus on the knee denervation, how it started. Well, the journey go back to 2011, when it's not something that we click and we will do it, but that was a very important paper. It's coming from South Korea. They say the user rate of frequency for chronic osteoarthritis. They actually said the design is so good that actually they were published in the journal, a very prestigious journal, Peng. And for some reason, unknown reason, they just say actually you put in free spot the supermedial, superlateral, and inframedial, and you can burn the supermedial, superlateral, and inframedial genital nerve for some reason. As I say, just for some reason. They produce good result. When you look at the Peng score, this is the control. They actually put the needle irrespective whether control or not. The control group, they put the needle but did not turn on the button, did not burn it. And then the one that with active intervention, they turn on the button and they burn it. So you can see that up to 3 months, they still have a very good result. And in terms of the percentage of the relief, with 50% relief, you can see this is the radiofrequency group. You don't see anyone that reached the 50% relief by 3 months. And not just the Peng score, but also the functional score is also good. Now, so remember how common is a knee osteoarthritis. So suddenly for a lot of Peng physicians, we just say, wow, this is great. But they leave a lot of questions for this, a lot of questions. So, but I'm going to talk about this later on, but when I look at 2016, look at those systemic review, there was basically just one RCT based on that study, but there's a lot of case series. But later on, when I did it again from 2016 to 2020, in 4 years' time, there's 13 RCT. And I would say actually it's 2024, we have even more RCT to look at this. But most of those studies are very positive. And that's the reason why suddenly it opened the floodgate. Everyone are so interested about this. So what lesson we learned? So the first thing about it, we call prognostic block. Well, remember, so for the spine, we say we need to do the diagnostic block to prognosticate whether the patient need a block, need a radiofrequency ablation or not. The debate is not whether to do a block, is to debate whether we should do 1 or 2 or 3. All right, so what about in knee? Well, remember, in spine, there's a multiple pain generator. There's a lot of psychological issue, but a lot of related to the disc, related to the muscle. So it's not that clear cut. So we need the diagnostic block. And as I say, there's a complex interplay with the psychological factor, well known for the low back pain model. And the radiofrequency ablation, because of cost consideration for cost, we would like to actually just make sure we screen and select a candidate. What about the total knee? Well, the one that we say that we don't need the diagnostic block because actually say in the knee joint, there's no muscle around. Actually, the quadricep is outside, so there's no muscle wrap around the knee joint. And this actually is basically, we think actually in elderly, the pain have to be inside, it's OA, so it's a restricted pain generator. And most of the time, we are dealing with a population, and it's true, has a less complex psychological factor. Low back pain, you can see a different type of group, maybe work-related, maybe actually someone in the 30 or 40. But this one purely, most of the time, I would say actually, mass majority, they are actually elderly. The psychological factor can be there, but it's much less complex. And and there's a high prevalence of we call the positive prognostic block. So someone have done this and find that actually when you look at all the population, if you do this, if you do the cases and you do all of them, 80% is positive anyway. So, and there's a small trial. Let me emphasize, it's a small trial. It's not a big numbers. They actually compare those prognostic without prognostic block, and then all of them they will have that they would have that radiofrequency ablation, and they actually don't find any difference between the two groups. So it sounds like actually we don't, but the proponents say I think is a good clinical practice. It's an invasive procedure. We'll probably actually just before you spend the money, commit all this time, just is a good clinical practice. And in real life data, it actually finds some usefulness. So there's 2 real life data, and one of them is actually this is one of the first big prospective retrospective cohort. They do regression analysis. They find out less than 50%. Between 50% when you have a pain relief more than 50%, there is a kind of a difference. But when you cut off point when you more than 80%, you make a dramatic difference. So it is not dramatic, but it's certainly actually it really prognosticate the diagnosis and the response. And again, there's another Korean study that show actually the difference between prognostic and non-prognostic block. You can see here, those with a prognostic block, they tend to respond a little bit better with a better outcome, 80% versus 60%. Again, it's not dramatic, it's there. So I think this is actually that is not something that we don't, it's complete shock. When you say that when we do a diagnostic block, we screen some of the outliner that may not respond, but is not a huge chunk. So where are we now? So I don't want you to leave you nothing. So I would tell you, and I've been speaking many times in different talk, and I'll say, let's face it, the pretest probability is high. Most of the patient will respond anyway. So, but then the problem is, not all the osteoarthritis need is different. If you have nothing to do tonight, after you drink all your wine, just Google phenotype, structural phenotype of knee osteoarthritis. Just Google these few words. There's a few good articles. And some of the phenotypes, they are neuropathic phenotypes. Some of them, so that means actually you touch them, they just jump. The pain is not mechanical. They pain all the time, or they have a very angry looking synovitis. So they are different structural phenotype. And yes, in some patients, just know that it is psychological, and some patients, for some reason, not happen in you, but in Canada, they are somehow on a high dose opioid, they are on methadone, all this. So I think in those patients, when you are not too sure, even though we know that most of the time it's always straightforward, when you have those suspect phenotype, we have a psychological, some risk factor there, I would rather suggest you to do it. The second is, whenever someone who have a post-arthroplasty pain, for some reason, my first 5 years doing this, I see a lot of patients refer to me, just actually they don't want the surgery, I just do it, great result, happy. And then somehow, something changed in Canada because it's so ludicrous. And a lot of pain centers, they open satellite pain clinic, they all do this now. So by the time patient, they grab all those straightforward patients, and then a surgeon take all the crazy patient when they have a surgery, but they're not responding, they send it to me. So I see quite a lot of those persistent pain after arthroplasty. So for those, I think it's very reasonable to do a diagnostic block. And the third is, sometimes in your practice, you just don't want to do it, or something you feel not right. You can always adjust the cutoff point to 80% to make it because by using cutoff point 80%, you see that much better candidate as I mentioned in one of the prospective cohort. Efficacy. Well, the first study show actually is fairly good, more than 50%. They have more than 50% of the population with 50% of a relief or more. When I do multiple systemic review, they all actually say the same thing. Well, but there is some backfire now. So something obstruct my, here we go. So there's two lines of those information in the literature. Just think that you need to rethink about this. The real life experience is not as grandiose if you use the free original target. So there's a two study they suggest. Actually, I see what I can. Okay, so I don't have a data, but actually, just for the interest of time, these two study actually is they actually are real life data. They look at a large number of patients. They find that actually compare free target versus the 5 target or more, and the free target are not that great. And when we look at the original article, well, first of all, we don't know why they choose the free target. The more they say, the more we find something wrong. And second, actually, is they use a lot of lidocaine, 2 cc of lidocaine, 2 cc. Wow, this is a pretty large volume. So, and then the needle they use is very small. So that means it is a small lesion with free target and small lesion. And actually, something that I don't understand, they say the responder are the one that have the prognostic bulk response more than 24 hours. That means you are selecting those. You touch them, they feel better anyway. So if you use lidocaine, they have a response for 24 hours or more, it will be the one you do. That means actually you select those who actually you touch them, you feel better. So now we actually say there may be a big problem. So this actually article is an editorial from my friend Stephen Cohen and say actually RFA in osteoarthritis that open a floodgate of a host of a non-sham control copycat. So the 13 RCT that I talk about, they are not sham control. They are actually compared with the so-called control is actually no treatment. So again, we have a certain limitation when we use a non-sham control. Okay, so that's two studies. Actually, need to actually look at this. One is actually the study by my group, my friends actually from Belgium and Netherlands. So they look at actually we call the co-gene study. So they compare. So this is actually not a control study. They compare conventional versus the Ku radiofrequency. Now, I just want to just show you. So no matter if it is a conventional Ku, at 6 month time, look at the success rate. Remember the Korean group, they are 50% or more. This is only 30%. As a matter of fact, a lot of those my colleagues actually tell me when they perform what choice perform, they are not getting the stellar result. They only get 30% or so this would compatible with what they are. And the whole group is around, if you actually lump the whole group, so they have two groups, one is osteoarthritis, the other is a post-surgical pain. When you compare the two groups, actually the success rate is even lower. So somehow there's something not good. And one of the reasons is, I think they target only free nerve. The other study is quite interesting. This is a sham control. So again, they virtually produce the same paradigm as the choice group. They put the free spot there. They actually they put a needle. One group they put a sham. They don't crank up the current so that no heat. The other they crank the current. But the difference with Troy is that they put the bipolar lesion, so it should be better than Troy. So when they look at this, basically all through the 12 months, they don't see a difference. They don't see a difference. They don't see a difference. So where are we now? So I think one of the important thing is a lot of time that there's initial enthusiasm about this. And a lot of people just do all this we call non-blind control, non-sham control, and turn out all this is negative. Remember that good olden days when we talk about we should use a hormone therapy with for menopause, they don't say it's harmful, they don't it's okay, they don't it's selective. The same thing as that in the good olden days, we have multiple sclerosis, we need to dilate the jugular vein, and turn out that is not good. So is it not effective? I don't think so. It's still effective. But I would say there is a problem with the free lesion. I will explain you a little bit more. So I think I have a little bit criticism on the past when from 2011 to 2010, there's a lot of studies positive. And my summary for this is, number one, the choice study actually have a lot of issue, especially they select the one, then the moment you touch them, they feel better. Just like your lidocaine, you select the one who respond to lidocaine more than 24 hours. And then later on, the floodgate of those study, they basically select those, they are using the non-sham study. So I think actually just doing free sport, it may work, but the effect size may not be that great. The number of those responders may not be that great. So always have a critical mind, and power of shams procedure is important. So it leads to my question. Well, for those who haven't seen this picture, too bad. Now you should see it. The knee is all covered by nerve, 10 in the front and 4 in the back. So basically, it's like the knee is like a reservoir. It's just flooded, covered with the fish everywhere. So, and why on earth we pick free spot for interrupting the Peng generator? Something for you to think about. Okay, so what are the optimal target and what are the number of targets? So this is a question that we need to think about this. So in terms of what is the optimal target, there's two questions here. One is we call the number of target is free is enough. The second is what choice say that free target, is it actually good enough? So putting a needle to us, so remember the free needle they put in is supermedial, superlateral, inframedial genital nerve. Are they really actually directing towards the nerve? So putting a needle towards a target doesn't mean that you're in a target. So I think no better than this picture. Putting a needle towards a target doesn't mean you are on the target. So we need some modulation study. So here you go. The two real-time real-life prospective study, they all suggest basically there's a difference between free the target to free or more. And here you see 4 have a much better chance, and also here 3 and 5 you have a better outcome. And it makes sense. You have your knee is swarmed by a number of nerve. So why on earth the choice they decide to free nerve, free little spot, free little pond, and say it will actually successfully and comprehensively interrupt the Peng target. All right, so because of this, I was my concern. And then there's another group, they go the other way. And I hope that you don't take my message wrong, but someone did. Well, Dr. Peng said there's 10 targets. Why not burn all the 10 targets? This group actually virtually get it to the publication in a good journal. It's a actually education article. Let me teach you how to do the 10 nerve. Give me a break. This procedure probably longer than the total knee replacement itself. And this number one, the time is much more consuming. Number two, who say you need 10. Number three, a lot of those procedures are, I don't agree. I don't think they are validated. Just give you one example. The nerve denervatus lateralis. Well, what did they say? Well, they say X-ray. You just use X-ray 5 centimeters superior to the upper patella, 5 millimeters towards the midline, and just 1 centimeter, just superficial to perosteum. Hello, give me a break. By the way, if you don't, let me just say, actually, I have a picture here. No, I don't. If you actually come to my workshop, I will come to Brazil 2 more times this year. Come to my workshop and we'll show you the nerve vastus lateralis is wrapped around between rectus femoris, vastus lateralis, and vastus intermedius. So it basically is defined by the soft tissue plane. Why on earth you can just do it in X-ray reliably with radio frequency? You're not just say doing diagnostic block, which basically you can inject a large volume and flood the whole area. Radio frequency, are you sure you know that? They never validate this one. As a matter of fact, there's a publication actually to talk about is in between the free muscle, just like what I talk about. And well, so not free, not 10. And And I would say, I'll give you a little bit idea what I would suggest. The other is validation of target. So this is actually what they talk about. Well, the free level, there's free sport, supermedial, superlateral, inframedial. So what they suggest is actually you put a needle between condyle and the shaft, and then it's around the midpoint there. Well, we'll look at what exactly they are doing. So this is actually what they are doing here. So, and then the only difference is we use computer to simulate what they are doing, and then to project on the cadaver dissection, on the number of dissection. And this is what they are doing. So when they claim they are doing the supermedial genital nerve, so what are they doing? This is a true supermedial genital nerve. There are 3 branches. What the choice group or more the follower of them, they burn is only one of the 3 branches of supermedial genital nerve, only one of the 3. But lucky enough, he also burned. There's a nerve to vastus intermedius, nerve to vastus intermedius. There's a medial and lateral branch. The medial branch actually come here, and he also burned a medial branch. Actually, it's the posterior part of the medial branch. So he actually said he lost 2 but gained 1. So it's not bad. So that's why he still have something. And the same thing happened to the superlateral genital nerve. He only burned 1 branch of the 3 of the superlateral genital nerve, but he lost 2 but gained 1, which is from the lateral branch of nerve to vastus intermedius. The inframedial genital nerve, he's bang on. So I would say actually the lesson I learned is, if you want to do this, I would say you need to perform more than 3 lesions. I think 5 lesions is fairly optimized, and I would like to just think about this. I talk about fish, and when you perform a radio frequency lesion, you catch one fish at a time. You burn one particular spot and one nerve at a time. And it's critical about the location, where the location is, and the size of a location. And in my opinion, when I do the radiofrequency ablation in this spot, I would actually do a strip lesion, a bipolar, or actually even sometimes I put 3 needles and actually catch a number of fishes there. And this actually is what I would do. So think about this. By doing 1, 2, and 3, I catch much more fishes and much more nerve. All right. So the next I would like to share with you is, well, Dr. Peng, if you say actually radiofrequency is like casting a line and catching a fish, what about actually using a net? You catch more fishes? Well, probably is the case. Think about this. If the knee is actually all covered by a number of nerves, if you actually have a way to flood it, actually the periosteum. Well, there's some nerves are not close to periosteum, but a lot of nerves are close to periosteum. Despite the variation, if you actually give some liquid there and just burn them, you can actually you can catch more nerve. So as I say, this is actually you can have bipolar lesion, 2 lesions, monopolar lesion, but alcohol phenolysis or those chemical neurolysis, basically you just put a lot of put some local anesthetic or put the phenolytic agent, you actually burn a little bit more target. Okay, so you can use phenol, 6 or 7%. In Canada, just because of limitation, I only use alcohol. Not because actually the wine and Peng symposium I like alcohol. It just actually the phenol actually that we use we have this is only aqueous 6%, which is not good enough. I like the glycerol 7%, but somehow for some bureaucratic reason, they removed this from Canada, so I can only use the alcohol. We have done this just to see whether it works. Actually, in Brazil, I think I recognize some of those are actually in this group here. So this is actually the proof of concept. 60 patients, and so is a prospective case series. It's very different from a lot of retrospective. It's a prospective. We designated with a lot of questionnaire to design. So sufficient to say basically is around 46% of them, they respond more than 50% at 6 months. So it's not bad. A lot of people say, wow, Dr. Peng, you are nasty. You inject alcohol. They can have a scar. They will have a stiffness. It's not good. Well, somehow we use a Warmack score. We probably know the Warmack score is a classical one for the osteoarthritis. They have different subscale. And look at this. One of the subscale is called stiffness. You can see actually stiffness is getting even better over time. That's because the pain is less, so they can actually do exercise. Now, this is actually the first time we have a biggest case series that ever produced for alcohol phenolysis. 2017, when I actually talk about this in US, they think I'm terrible. They say, why don't you use radio frequency? So basically, I look like I'm an idiot. That's a 2017. 2018, I talk about this. And there's something actually, there's no one say I'm bad. They say, yeah. So no, I don't know what they're talking about. So just somehow no yes, no. 2019, they signed me. So in a big meeting, in a big symposium, I'm being assigned to talk about hip, and someone is going to talk about knee, one of the big centers. So when they talk about knee, they spend actually 15% of the time to talk about how good is the alcohol. So at that time, I said, wow, I better actually hurry up. I really need to publish that big case series. And that is a big case series. And before then, everyone says it's terrible, but actually this one show the feasibility. You look at actually the long-term outcome is good, except there's a swelling. So what is a swelling? So let me explain a little bit. So the study actually, I taught one of the author how to do it virtually. I didn't actually teach him how to do it in person. So, and one of the important thing about this is make sure your needle is perfectly deep to the muscle, between the muscle and the bone. So when you insert the needle, sometimes you think you are in the bone, but turn out actually you are just indenting the muscle. So your needle may still in the muscle. So when you inject the alcohol or the neurolytic agent into the muscle, you can cause myositis. Most of the time it's self-limiting, but actually it causes swelling and pain, and it lasts for a month. But second month, all this disappear. But after we actually meet in person and just refine the technique, and it doesn't happen anymore. This is a few of my competitor, and they publish a lot of those. And one of this is actually chemical analysis of the genetic nerve cohort study, and 85% more than 3 months follow-up. And so again, at the time of follow-up is around 43% more than 50% better. So our is at 46%, but it's 6 months. So mine is probably better a little bit better than they are. Now, just let me see. This group of investigator, actually, I know of them. Interestingly, actually, when we have a little bit of debate the year before, they told me that actually, since I convinced them to use alcohol, they try, and one of the things that primed them to do this procedure, to this study is he have a patient who have a radio frequency but have a failure, and then later on he used alcohol, and the patient get much better, and the patient actually was so excited, but then just say, doctor, why don't you do alcohol right from the start? So that actually make him just excited and do alcohol and all this study. All right, so what are the lessons? I think alcohol, I like it because easy, fast, and safe. Now, one of the most important thing is about the volume. Now, remember, we keep talking about radio frequency. We need to use the smallest volume, 0.5 and all this. This one I can use 1.5. If I use alcohol 1.5, I can use 1.5. If I use alcohol 1 cc, I use 1 cc here. So I can use basically the same volume of local anesthetic as my alcohol or the neurolytic agent. And because it's liquid, it catches more nerve and is more affordable, much more affordable, much faster, easy, but more affordable. It's not that expensive. I think if you buy just 100% alcohol or neurolytic agent, it's usually cheap. Now, you use 100%. If you buy the Amalone, which is actually $50, that's different. But But if you actually buy just 100% alcohol, much more affordable, you don't need any equipment. So I think for the interest of time, I have much more lessons, but I just give you a small lesson. Now, for those who actually are in the workshop, they always say, yes, let me teach you something. When you do the ultrasound, you need to just the conda, epiconda, and the diaphysis, you see the supramental genital artery, and that is the target. Then you should just follow this. So using the superior medial genital artery as a surrogate for superior medial genital nerve. Don't trust them. So if you have nothing to do tonight, again, after your wine, nothing to do tonight, just actually Google DGA, descending genicular artery. And even they have a meta-analysis. I don't know why anatomy have meta-analysis. So a lot of interest in this particular artery. Why? Because the plastic surgeon have to do a flap. So basically what you can say is that there's a different pattern, but in general, the DGA send free artery there. And one of them is a supramental genital artery. So you can just know right away, in this region, there are 3 different arteries here, 1, 2, 3. And the supramental genital artery can be in, let me see, can be absent, or actually can be in vertical form. So you may not see all the time. As a matter of fact, when you see the artery, you probably see the other artery. So to use the artery you see, you are not probably seeing the supramental genital artery, and is not seeing your supramental genital nerve. So I would say the best is to use a landmark to guide you. Okay, take home message. Prognostic block is not as crucial as a spine intervention. I would say actually I still do it with discretion, but I won't bet on this. If someone is elderly or someone have some other issue and is actually quite straightforward, I just go ahead and do the procedure. But in general, I like to just do a diagnostic block because I don't like to see the patient just for half an hour and just do some major intervention. But I can waive this if there is a particular reason. The current RFA technique is effective, but I think there's a lot of room to improve, especially we probably have to rethink why we need to just cover that 3 tiny little area. And the conventional target cover not exactly the supramendial and supralateral genital nerve. It covers part of them, 1 over 3 branches, but somehow it also covers the other branches as well. That's why it gives some effect from the radio frequency. I think that the literature, more and more literature suggests we need more target. And for me, I would say I always do 5 target and produce very good result. And the chemical ablation is the one that I prefer, faster, easier, and cover more nerve. I use it as an alternative to very good radio frequency ablation. So there's many lessons that I need to share, like compare with different machine. There was a bipolar and what major and a lot of things. I'm not going to share with you, but I would like to just finish here. So and leave some time for question and from the group. Thank you very much. Are you all asleep? I hope not.
Thank you, Peng. Thank you very much. Great presentation. I would like to know, Peng, exactly how many spots are your target? How many targets do you use normally? Okay.
Okay, so Jose, just unmute me, so now it's okay. So in general, again, we have collectively more than 100 patients. So I right now there's so many retrospective studies, so there's not much point for me to publish. I can tell you right from the start, I've been doing much more than 3 targets. So I use alcohol, I use 5 targets. The 5 targets are the supramendial genicular region, supralateral genicular region, and the inframedial genicular nerve. But also I supplement with the nerve to vastus intermedius, the medial and lateral branch, And the medial and lateral branch, basically one finger breadth above the patella in the anteromedial and anterolateral of the femur, sorry. So these are the 5 targets. Now, if the patient in the X-ray and clinically have a lot of pain in the lateral compartment, by the way, the knee have 3 compartments: the medial femoral, tibia femoral, lateral femoral, tibia femoral, and the patellofemoral. If the patient have a lot of those lateral components, so most of the time they just have the medial component involved. If the patient have a lot of pain in the lateral part with a significant disease in the lateral component, I will supplement the recurrent fibular nerve. If the patient actually have a lot of a patellofemoral disease, especially in women, or someone who have some recurrent patellar dislocation, have much more collapse in the patella, then it will be a little bit tough. I will tell the patient, I will still do the conventional one, but in case that they have a partial effect, I will do the nerve devices in the radiofrequency ablation of the nerve devices medialis and nerve devices lateralis. These 2 are in between the muscle. I have to do the radiofrequency. I cannot do the alcohol, but I will not do it as a routine. So basically, I do 5. But actually, depends on the clinical context, I do more.
Okay. Thank you. Cecília, André.
Congratulations, Philip. Shouldn't the deaffiliation pain be a concern when we're talking about peripheral nerves thermal radiofrequency?
So if I hear your question is there any backfire when you burn the nerve?
Yeah.
Okay,
Perfect.
so actually, there's 2 things that. Okay, so to backtrack a little bit, the reason why Andre asked this question, because people talk about charcoal John. Actually, you burn all this nerve, all this, you can actually get your perfect pain, or actually get some bad consequence. There's 2 concepts need to be revisited. First, actually, the charcoal joint is not likely because we actually we burn part of the nerve. We are not burning all the nerve. And charcoal joint have something is a complete denervation, and also they destroy the vessel. So we don't destroy the vessel. The second is actually the neuropathic pain. The good olden day when we put chemical or destroy the nerve, why they have a nerve pain. Reason is the nerve are not dead. So if you have a difficult understanding, just think about this. So you are putting on a jacket, a winter jacket in Canada, and someone pours some acid to you, or actually torch a fire to you, throw a fire torch to you. You won't get killed. You just burn your jacket. You just get angry. You get a degree burn score, and you get angry. But you can actually come back with a vengeance. So this is actually the good olden days when we deal with those nerves. We are actually not precisely where they are, and we are actually dealing with those nerves with a myelin, develop protection. What are we dealing with this? The articular branches are the smallest of the nerve. They don't have myelin. And just like bullying, you bully the small guy. I just give you one example. Say the hip nerve, a femoral nerve articular branches, you can have divided into 14 articular branches. So even superior genital nerve, they come to the 3 main branch, they divide into 3 main branches, and then each one give 3 or 4. So they are so thin, they don't have myelin. You put the alcohol there, they are just dead. They have no chance to come back with a vengeance. And that's the reason during the COVID, a lot of people talk about, yeah, should we use steroid at the end? Do we use steroid to prevent the neuritis? Conventional wisdom, right? And turn out that a lot of centers, they don't use steroid. For that 3 years, we ask around, none of them see the neuritis. So that's actually the concept that if we do, but conventionally we say, well, we injure the nerve, we worry about the nerve come back with an invention. But if you think about the pathophysiology, it's actually very, very unlikely.
Thanks.
Vou pedir aqui pro Cissa, quer fazer alguma pergunta? Vou pedir para o Razen. Razen, habilita seu som aí, se conversar com o Peng aqui também.
Hi, Philip. How are you?
Oh, Hassan, we are here.
Yeah. How are you doing?
So are you ready to dance in Copa?
Probably, yes, yeah.
Okay, so everyone here, we have 170 people say Hassan is going to dance in copper. Okay, good. Carry on. What's your question?
Actually, there are two questions, but I'll start with one. Philip, we're we're trying to do the 5 points that you block, and we actually our FINO was 5%, and it didn't work well. Then we bought some FINO 7%, but it started to be very painful during the injection, similar to ethanol, or not like ethanol, but because sometimes we don't sedate our patients in hospitales clínicas. So it was hard to perform, and but the results were not actually good. Like we had, they were pain free for 1 month, 40 days. So I don't know what problems are we facing actually.
Good question. So actually, so you are not alone. For some reason, something about the glycerol. So I have two groups. One is in the University of Montreal and also McGill. They approach me. They use 7%. They compound that one. Again, they don't see a good result. So there's something peculiar with the phenol, the construction, and it's supposed not to cause pain. But when we use alcohol, we don't see much problem. So I have been, well, I would say actually, I just use probably maybe a couple of patients with the 8 to 6%. I just forget it. I've been using alcohol since then. So the alcohol, yes, it cause pain. So I usually do that. So I have 5 target. I actually put the local in 3 target, and then after just local first, and then I just wait. And a lot of time, because I'm teaching center, I do it. I actually just say, let's check an X-ray and let's just do a bit ultrasound and I keep the needle there, and just wait a little bit for probably maybe 2 or 3 minutes, and then I inject the alcohol. They usually tolerate fairly well, and then do the second part, and the putting the needle is so fast. So I would rather actually wait for 2 or 3 minutes, let my local anesthetic to soak in, and then I put the alcohol there. So I don't have any particular issue with the alcohol. I don't know, there's something have to do with your phenol compound. And by the way, actually, have you tried alcohol or?
Oh, we did the way you're saying, like we anesthetize first, and then
Did you wait?
Sometimes we wait, but do you think it's better to keep the needle and then you inject
You keep the needle. You keep the needle.
Yeah.
We don't take out the needle. So why just keep the needle? It's just actually I don't have any problem. Just do nothing for 2 minutes. Just talk. I love to talk. So I keep the needle, put the thing there. Just talk. What do you have last night? What wine you like? And then after all this 2 minutes, and then put it in. So and 2 minutes is not too much of time, but
it's not too much.
Make a difference for the patient.
Yeah. Okay. Yeah. Thank you, Philip. Oh, Philip, and for the vastus intermedius, do you insert 2 needles, one for the medial and one for the lateral, or you use the same entry point for both sides?
The vastus lateralis, if you invite me when I'm in copper, I'm more than happy to show you or actually get some patients. So the lateralis is a little bit easier. So you just 1 finger breadth above the patella.
Yeah.
You look at the rectus femoris. You see it. There's a muscle tendon. You actually so you do a short axis above patella. Just go to the lateral side. You start to then you see the intermedius muscle wrap around the femur. So the lower layer is intermedius, and the upper from rectus femoris transit to lateralis. The transition of this, if you tilt the probe, you see a line between the free muscle that is very consistent is vastus lateralis.
Oh, okay.
Intermedius will be a little bit tricky, so you need to have a mentality of fishing. So you actually go to the vastus medialis. You actually look for the vessel, and look for the pattern. So these two really help you. If you see a vessel is a no-brainer, that actually means the nerve is around. But look at the pattern. The muscle pattern look like when you have a piece of stick, you have a triple A, and then you have a little bit of marble pattern. But the nerve actually gives you a very different, we call static, like a star, a crab-like pattern. Then you know that's a nerve. So that actually is usually for the muscle medialis, you see 2 or 3 spots of those fine nerve around. So I would do that, but this is intramuscular. So I use a radio frequency ablation for this.
No, I mean for the intermediates.
Intermediates, the middle is easy. So one finger breath about the intermediate, the patella, and have the needle directed to the anteromedial and anterolateral of the femur. In the X-ray, it is basically in the anterior 33% of the femur.
No, but you enter with the 2 needles or the same needle from the lateral side, then you
Oh yeah, 2 needles.
to the 2 needles. Okay.
So 5 target, 5 needles.
No, okay.
I don't shortcut anything. So
Oh, thank you, Philip.
Cissa,
Just to end, there are questions from the audience. Do you inject contrast dye for assess the spreading of the alcohol injection? They want to ask you, no. Okay. From Ildefonso. Dr. Philip, patient satisfaction after a total knee is about 80%. Do you think there's a role to denervate in the... There is something here that I can see, but from the surgery, I don't know if
are you talking about before the surgery, or who asked this question? Can you unmute yourself and ask me directly?
Yeah. Dr. Ildefonso. Oh, he's asking if you perform, if maybe he's orthopedic surgeon. Maybe he wants to know if you would say that it would be good to perform the denervation and at the same time of the surgery.
No, I think, Cecilia, I think the question is, surgery is so good. Why performing radiofrequency? That's the question.
Oh, okay. Instead of.
Yeah. Why are we talking about innovation if you have a good weapon like the surgery?
Oh, okay.
So actually, it is a good question. So let's face it. In terms of different surgeries, some of them are very gratifying, very successful, and the knee surgery is a very gratifying, very successful surgery. Let's face it, it is the case, and the hip surgery is also the case. So why would we do this? So there's multiple reasons. So number one is actually not everyone wants to have a surgery. So or the patient want to have a surgery cannot actually have a surgery. Say they have a significant comorbidity, and so they just worry about they cannot tolerate the surgery. They have the cardiomyopathy. All this, or actually patients who are morbid obese. So the surgeon say, well, you need to actually lose 100 pounds. But then it's a vicious cycle. So there's a reason that so number one is that they cannot have surgery. The second is some patients actually talk about the stiffness. I give you one of the situation, and I believe that one of a peak surgeon here, you can actually confirm. I remember actually when I talked to the group of a big surgeon, and one of there's a patient actually in that group. The patient is a grandfather. The reason why he wants to have a knee surgery, he wants to squat and pick up the grandchild. And then after he have a surgery, turn out that actually is maybe the rehab problem, nothing to do with the surgery. Actually, the knee is much more, the stiffness is much worse. And he actually cannot even bend down at all. So, so this is something that, and then surgery is done, we can't reverse. So there is something that actually is the other possibility. And the third is actually we are dealing with quite a number of those 20%. That means actually have a knee surgery that they are not getting better. So we are looking after them. So I agree. I don't contradict. Actually, knee is a very successful surgery. I am not competing with the surgeon. If the patient wants to have a surgery, the criteria is more or less the same. It's actually when they have a moderate to severe pain with a moderate to severe osteoarthritis that refractory to the physio and the conservative treatment, then they can actually consider surgery. Or actually, if they don't want a surgery, they can actually consider this one.
Yes. In each
By the way,
case.
I just let you know, in Canada, we are a bit better. The wait list is probably 6 months in the downtown area, but will be much longer in the remote area. But in some country, when the wait time is like 2 to 3 years, something for patient to choose.
Yes. While waiting for a procedure, maybe you can offer something while they waiting for total knee arthroplasty.
Well, remember, the time will pass. So you can wait for the surgery, which is good, but the
Yes.
deterioration of the body condition will not wait for you. So when you just cannot walk, you gain more weight, you get more decondition, you get less active cardiovascular muscle loss. So that is actually a social problem that we have.
Yes. And then you answered the next question, because if they don't have the condition and there is an option before even surgery. And also we have to phenotype all the patients, because the choice of the procedure depends on the clinical presentation and clinical conditions.
Good.
Peng, just to organize our thoughts, what you think about cryoablation, radiofrequency ablation, neurolysis, and embolization? It's possible to compare and to choose any techniques in
So let's talk about this. With the frequency ablation, I think so. If you think about the knee is all wrapped around the nerve, and what your aim is, the aim is to cut down some of the pain generator. So with your frequency ablation, need to cover more nerve, or you have a bigger lesion. So it's still workable. I'm not saying it won't. It just take a bit more time, but need to involve more nerve. Alcohol will be easier. Just put a needle there and cover more nerve. You need to have a stronger medication to cover. I use alcohol, and so far all this result is very reasonable. And embolization. Now let's talk about embolization. It's a kind of a misnomer. So the embolization 2017, the Japanese group produced. The group actually is now they do something different, but in general, the large case series from them is not to. So when we talk about embolization of the genital artery, what do you think? They are not actually embolizing the genital artery. So what they do is they do angiogram first. They see the brush. That means the neovascularization. So the supermedial genital region, they look at the artery and see any brush, the neovascularization, and they embolize the neovascularization. They don't actually kill the inner artery. So, and basically the prospective cohort and they publish at RCT. They have a good result, but if you ask him, he still think that actually, if someone is have the bone on bone or terminal disease, they don't suggest. They don't suggest doing this. So we are but this is the one that I love to have you to do this, but they are not. The cryo, I actually do cryo. The lesion is big. There's a lot of reason that it should do well. Somehow, maybe I'm just a clumsy hand. I've done quite a number of, I would say as much as the radio frequency. I've done probably maybe a dozen. I don't get a convincing result. Just like Hassam talked to me, well, my pheno doesn't get result. Actually, that doesn't get good result. I don't know. So if someone who have done some cryo with good result with drunk enough, you can speak up. You ask me, I don't see it, and there's not a lot of publication on that area as well. So so there's actually comparison with the 4 different techniques.
Thank you.
Andre, did you do any cryo? Do you have any good result or? Andre Mazzano.
No, Philip, not for knee denervation. I perform cryo for, especially for nerve entrapments, ilioinguinal, iliopagástric, genitofemoral, sometimes trigeminal, but not for knee denervation. So expensive here in Brazil. So expensive.
More questions? Mais alguma pergunta aí, pessoal? Vamos liberar o homem também? Ok.
So if there's no question, I think everyone is tired. Do you see any questions there? Or I don't see any questions.
No, Peng. Once more, thank you very much for speaking. Well, it was a big pleasure. It's an honor. I said before. Thank you very much. And
Honor is neutral. Yeah.
I would like to invite you for the next Brazilian Congress, the Sobre Congress in next year, 2025. I send you an email. I mail you.
If I still working, not retire.
Yes. Thank you. Thank you very much.
Thank you. Thank you.
I love your wine.
But try it. I'm lonely. Take care.
Yes.
Bye.
Bye. Até logo, eu vou falar rapidamente, pessoal, os sorteados aqui. Um minutinho. Nós tivemos aqui, ó, Amélie Vieira Falcone, de Juiz de Fora, Bárbara Nicole Reluani, Diego Dosa, José Marcelo Ramos Rodrigues, Marcos Vinícius de Moraes, Marcela Arantes Fernandes. Então, eles foram sorteados, a nossa secretária da Sobramídia, aí, a Kátia, vai entrar em contato, e eu agradeço a participação de todos. Uma ótima noite a todos. Tchau. Tchau, tchau. A Una aí.
Doutor Zé Luiz.
Tchau, Una. Que bom te ver, viu?
Bom te
Tchau.
ver também. Tchau, tchau. Boa noite.
Boa noite.
Excelente aula. Parabéns.
Tchau.